Good afternoon. Hi, I'm Mary Beth Donahue, President and CEO of the Better Medicare Alliance, and really appreciate you joining us today for our MA rate notice, an annual webinar that we provide to our allies. So thanks again for joining. And for any of our allies who are new to the MA community, this is, as I was referring to, the administration is required to publicly release annual payment rates that determine the funding for Medicare Advantage each year. And the process begins with a public release, which just occurred last week, of a proposed rate of the payment policy modifications. And so we're in a public comment period that will go to March 3rd, and it's an opportunity for our allies to comment on the advance notice and how it impacts their work for MA beneficiaries. And we're here as a resource for you during this time. And we have our expert with us, Matt Kazan with Avalere, Managing Director, who will go through the various components of the advance notice and provide you that overview. Before we started, though, I thought I would just share with you, and as many of your organizations are doing, as much as this is a very complex advance notice and requires very thoughtful time to review it. Based on initial review, we are having serious concerns with what's been proposed in the advance notice, and a cut that would have a potential impact on MA beneficiaries. And so we need to look at all the proposed policy changes that combined would bring cuts to Medicare Advantage. And so we'll be weighing in on that in the comment period, and welcome feedback from all of you as you're completing your reviews, and if you're issuing any kind of statements or materials to inform us on what you as our allies are seeing in the review of the advance notice. And the reason that we have these serious concerns is ultimately they would lead to higher costs and an impact on the benefits that the 30 million beneficiaries are enjoying and benefiting from. And so it's important in this comment period window, as we provide those thoughtful comments, and because the window is so short, we want to be able to continue to advocate to strengthen the program. And as we're seeing any cuts, we want to be able to communicate that we can't have these cuts because of their impact on beneficiaries. And so I want to be able to turn to Matt, but at the end, I'll just have some additional comments after Matt's gone through the overview. And I know the program will be, Matt will provide the overview, and then we'll be able to take questions that we want to make sure we're responding on a substantive level to any questions that you may have about the advance notice. So I'm going to turn to Matt. I've had the pleasure of introducing Matt many times before. He's a managing director of Avalere, to those who have not been on our webinars before. And he also has extensive experience working, having worked on Capitol Hill on the Senate Finance Committee under Senator Baucus and Senator Wyden, and is an expert around town and at a national level on the regulatory policy landscape, specifically in the areas of MA and Medicare Part D. So Matt, I'm going to turn to you so they can hear from the expert here, and then we'll move to questions, and then I'll have a few more things to say at the end. So thanks very much.
Very good. Thank you, Mary Beth, for the intro, and BMA for the invite today to run through the advance notice. So I think we have a couple of slides that we will run through. So once we get those up on the screen, we will start. Perfect. So my goal today is to kind of run through the major provisions in the advance notice, talk about potential impact on the Medicare Advantage program, and talk about where CMS may go from here. So let's dive in. This advance notice obviously comes in parallel with the proposed rule that we went over on a previous webinar. I think the distinguishing between the two is important. The annual kind of proposed rule is much more of a kind of policy document where CMS proposes changes to things like star ratings, network, etc. The advance notice, which we'll be discussing today, is much more a payment document. What is CMS proposing to pay both Medicare Advantage and Part D plans for the following plan year? The advance notice is on also a slightly tighter timeline in that, as Mary Beth mentioned, this was released by CMS not too long ago. Comments are due on March 3rd, and CMS is statutorily required to put out a final notice, final rate notice at the very beginning of April, first Monday in April, which this year falls on April 3rd. So a lot of activity, a lot of comment making around the Medicare Advantage program between now and the beginning of April. Do want to remind folks that that comment period for the proposed rule is set to close next week. So February 13th is the deadline there. So obviously keep track of both documents as you think about a potential response to CMS. All right, so let's dive in on the advance notice and what CMS did, and equally as important, what CMS did not do. So if we advance, I think 2 more slides here. Actually, before we get to that, wanted to highlight some kind of top line numbers. And I think what's notable about this slide is that it really illustrates this is a different type of notice that we've seen in previous years. Both you can tell from the 22 rate notice or rate announcement and 23 announcement, these were the final policies that CMS put in place. You could tell the difference right away in terms of the individual components as well as the overall expected revenue. And the reason that is different this year is really because of explicit policy decisions that CMS has made that we'll dive into, both on the growth rate calculation, some pretty substantial changes to the risk model, and changes on the star rating piece, which aren't really in this notice, but a function of kind of other policy changes that CMS has made in previous documents. So now let's advance to the next slide and we'll dive into each of these pieces together. As I said, right, wanted to focus on not only what CMS is doing, but what CMS is choosing not to do, because that can be equally important from a policy perspective. So big major proposed changes that CMS is making is around a kind of technical change around excluding medical education costs in the calculation of how MA plans will get paid. So we'll dive into that. That's a big change. And then they're making a pretty fundamental change to the Medicare Advantage risk model that will have an impact on the program writ large, as well as kind of a differential impact on plans depending on their enrollees' composition. CMS is not making changes related to how they set payment rates for ESRD payment to plans. And notably, they are not making any changes to the Part D risk model, even though major changes to Part D are being implemented in 2024 as a result of the Inflation Reduction Act. So we will dive into all those topics in greater detail. I think if we go to the next slide, we'll focus on this first one, which happens to do with medical education and the growth rate. So MA payment, as I assume most folks know, is largely based on fee-for-service spending and changes in fee-for-service spending from year to year. And so CMS, as part of the rate notice each year, kind of calculates how fee-for-service spending is evolving over time. This year, as part of that calculation, CMS is excluding payments that CMS makes to teaching hospitals for direct and indirect medical education costs. And that has the effect of kind of lowering the overall growth rate of fee-for-service, which then translates to a lower than otherwise would have been benchmark rate or payment rate or update on the MA benchmarks. And so you can note from the slide here a potential reduction of a little over 2% on most of the MA rates due to this particular change. And so if you, and folks can receive these slides after the webinar, but if you refer back to that larger chart that showed the differences in growth rate, this is one of the major reasons why the fee-for-service growth rate looks different this year than it has in previous years. So that is certainly a significant change that CMS is proposing as part of the rate notice. The other big change is on the risk model, which we start to talk about here on the next slide. This again is a very significant change for the program and for plans. So let's advance one more slide. Perfect. So CMS is making a couple of different changes, and I think it's important to talk through this kind of in a stepwise basis. So CMS is doing a couple things here. They are kind of redoing the risk model using ICD-10 codes rather than ICD-9 codes. So several years ago, kind of healthcare system moved away from ICD-9 more to ICD-10, right? More codes, more granular look at conditions and diagnoses. And so CMS is recalibrating the model using ICD-10. And so that alone changes quite a bit how the risk model would look. We'll talk about it here on the next slide, which we will not go to yet, but preview. A lot of codes are getting removed from the risk model that are currently present in the current model. And that's going to rejigger which conditions are incorporated into the model. And so, as you know from this slide, the total number of HCCs is different under this proposed model compared to the current model, going from 86 to 115. So that alone is important and definitely has an impact on the program. The second big policy change that CMS is proposing is related to a choice that they're making around differences in coding between fee-for-service and Medicare Advantage. They also, after taking a look at the kind of transition from ICD-9 to ICD-10, took a look at which codes are more prominent in the Medicare Advantage program than in the fee-for-service program. And CMS states that they did remove some of those codes for that reason. So taking both those changes in combination, the ICD-10 transition and this analysis around comparing fee-for-service and MA, CMS states that this change would reduce payments to Medicare Advantage plans by a little bit north of 3% in 2024. Now, of course, that's an average, and certain plans and certain conditions are going to be treated, are going to see potentially different results. So if we go to the next slide, we put out a quick analysis, and you can access it at avalere.com, around some of the more kind of prominent areas where we're seeing an impact, some of the top conditions where we're seeing codes being removed from the model that's proposed compared to the current model. So again, a little short of 2,300 codes are being removed from the model, but for conditions like depressive disorder, diabetes, vascular disease, those codes, the codes related to those conditions are seeing a pretty substantial impact in terms of the number of codes removed. So it's going to be important for plans and for stakeholders to take a look at this in terms of a kind of whole, how does it affect the model on average and writ large, but it's also going to be very important for folks to take a look at plan-specific impact and potentially condition-specific impact, because that will certainly vary tremendously depending on how these near 2,300 codes shake out. So we certainly have been doing a lot of work in this space, and I know the plan community is very much focused on this change. So I suspect that this is one area where CMS is going to receive quite a bit of feedback and comments on. We go to the next slide. Some other changes to the risk model, potentially less controversial, a little bit more technical, but I think still worth noting for our purposes here. Number one, CMS is using or proposes to use more updated or more recent years of data to calibrate the risk model. The current model uses 2014, 2015 data. CMS is proposing to update that to 2018, 2019 data. And CMS is also proposing to update what's known as the denominator factor, kind of the expenditures that equals the average for the risk model. They had been using 2017. They're proposing to use 2020 data for purposes of next year's next year's plan year. So more technical changes than I think some of these explicit policy changes that we just discussed on the ICD-10 transition. We advance to the next slide. Moving away from the risk model, but still focusing on MA payment. And I know this has been an area where BMA has been active in previous years, so definitely wanted to highlight an area that CMS is proposing not to make any changes, which is around how Medicare Advantage plans are paid for enrollees who have ESRD or kidney failure. MA plans are paid differently for this population. They are paid based on the average fee-for-service spending at the state level rather than at the county level, which is done for non-ESRD enrollees or most of the enrollees that are in MA. There's been a lot of stakeholders that have discussed some potential downfalls or consequences of this type of policy and have suggested using a different geographic area to base payments on, such as CBSAs. This rate notice, as well as last year's rate notice, CMS did acknowledge that stakeholders have discussed this and have summarized some analyses that CMS has done to try to evaluate whether or not they should move to CBSAs. In this year's rate notice, CMS took a look at the kind of health equity impact of moving to a different geographic area. And while the analysis is a little bit unclear, CMS states that they concluded that doing so would disproportionately cut payments in areas where we do see a lot of enrollees facing social risk factors. So based on that conclusion, CMS decided not to propose any changes to the payment methodology for ESRD enrollees. If we advance one more slide, shifting a bit away from payment and towards star ratings, CMS is soliciting comment on a couple areas that we did want to highlight. Now, as I said at the top, most of the major changes to star ratings are put in the annual proposed rule. And we talked about that on the last webinar. There were some pretty substantial star rating proposals in that rule around health equity and this health equity index that CMS is contemplating. CMS often puts maybe relatively more minor proposals around stars in the rate notice, or other areas where they're maybe not proposing something, but are certainly soliciting stakeholder feedback. And that's what they're doing here with this program that they're kind of talking about or entitled this Universal Foundation. And so I think the goal that CMS has here is that Medicare runs a lot of quality programs, and there's lots of measures in all of those programs, and responding to stakeholder concerns that this is a lot to keep track of, and maybe there's some inefficiencies or lots of measures to follow. CMS is trying to figure out, can they come up with some sort of measure set that is the same across multiple programs? And so that's what they're referring to when they say Universal Foundation. And so they took a look at some of these kind of adult quality measures, what should be in every payment program. They don't preclude adding other measures that are not included in this Universal Foundation type model, but they kind of want to have a common denominator, so to speak, of measures. And so CMS did in the rate notice or advance notice list those measures that are kind of currently contemplated in this Universal Foundation kind of set, and crosswalked them to what is in the current 5-star rating. Some of them are currently in the measure set, some of them are display measures, some of them are measures that CMS is proposing to add. So it gives a little preview of CMS's thinking of maybe the evolution of the 5-star rating system. But importantly to stress that in this advance notice, CMS is not proposing to make any changes, but really only signaling where they may go in future years, and probably would do so in a formal proposed rule, final rule process rather than a rate notice type cycle. Similarly, on the next slide, CMS also discussed, but again did not propose, adding several new star ratings in future years. And I won't list them all off here, but you can see there are a number of areas around blood pressure, kidney health, mental health, etc., that CMS is soliciting comment on whether or not these particular measures should be added in future years. So certainly important for stakeholders to take a look at areas of interest, those particular measures, the specifications on those measures, and really ask, would it make sense to add these measures to the 5-star rating system going forward? We go one more slide. We've talked about this before. CMS and the administration writ large obviously has a large motivation to focus on health equity. They do so a bit here in the advance notice, maybe not as much as they did in the proposed rule, but they did discuss a potential proposal around changes to some HEDIS measures, plan reporting on star ratings, but they really referenced this potential change to the star rating system that was proposed in the proposed rule around this health equity index, where again they would measure plans performance for a subset of enrollees that face social risk factors and reward certain plans and certain contracts that are doing better than others on those measures for that subset of enrollees. So again, that's still in a proposed stage. We don't know if CMS will finalize it, and if they do, in what form. But in the advance notice, they refer back to that proposal in the star rating section here. So we advance one more slide. Certainly, much of the advance notice was talking about changes to Medicare Advantage. I do think there are some important things to flag related to Part D. Obviously, most Medicare Advantage plans offer Part D, so this is obviously relevant for Medicare Advantage, but for the Part D program in particular, a couple things that I wanted to flag. They do update the benefit design parameters. The growth rate that CMS uses to update those parameters was much higher in 23 than it was in previous years, and so those parameters will look a bit different. CMS is implementing implementing all of the provisions that take effect in 2024 that were included in the Inflation Reduction Act, and there are a decent amount of those. Beneficiaries will no longer pay cost sharing once they reach the catastrophic phase. There's that out-of-pocket cap on insulin. There is no more cost sharing for ACIP approved or recommended vaccines, an expansion of the LIS program. They are implementing all of those changes to the Part D program as they are required to do under law. The one thing that they are not doing, which I do think is very important to flag, is that unlike the changes to Medicare Advantage's risk model, CMS is not proposing any changes to the Part D risk model. There are two separate risk models for MA and Part D. And even though the benefit parameters and plan liability in Part D in 2024 will look different than it does in 2023, CMS stating that they did not have enough time to make updates is proposing not to make any changes to the risk model. And I think this does have a potential impact on plans if and whether or not those payments will be accurate for conditions and enrollee types that are impacted by some of these IRA changes in the benefit that do take effect in 2024. So this is something certainly to focus on, especially for MA plans that offer Part D, have lots of Part D enrollment, for standalone Part D plans, for benchmark Part D plans that enroll low-income enrollees. This is something in particular that I would take a look at and analyze, because I think this potentially has a decent impact on plans going into next plan year. So lots going on, not only in this advance notice, but in the proposed rule. And so just wanted to lay out in our concluding slide here, kind of CMS's process and when they will make some of these final decisions. So, previously in December, CMS did release that proposed rule that I referenced a couple times with changes around star ratings, networks, marketing, etc. Comments for those, for that rule are due by February 13th. We obviously had this advance notice being released at the very beginning of February. Comments for the advance notice are due March 3rd. CMS will be required to finalize the advance notice. That will come first by April 3rd. CMS does not have the same type of statutory requirement to finalize the proposed rule by a date certain, but they certainly want to finalize that with plenty of time to give plans in preparation for submission of bids, which are due June 5th for plan year. CMS will then analyze and approve those bids, so to be ready for open enrollment, which of course everyone knows starts October 15th and runs through December 7th. And much of these changes will then be effective for January 1, 2024. So a lot of activity in the near term, a lot of opportunity for comments, not a whole lot of time. So we would urge folks on the areas that they feel like are important to comment on, get those comments into CMS very shortly. So with that finishes my prepared remarks. As Mary Beth said, I am more than happy to take any questions that folks may have on the material. And I will pass the mic over to Greg to read off some of those questions.
Thanks so much, Matt. Really appreciate the in-depth overview of the advance notice. Really helpful information. I know we have some questions coming in from the audience here, but wanted to start off with a couple. Obviously the advance notice includes a number of significant both payment and policy changes, for the upcoming year. What are kind of 2 or 3 of the most impactful changes to Medicare Advantage that stakeholders and BMA allies should be focused on or concerned about as they, analyze the payment notice and think about their comments here?
Well, number 1 would be the MA risk model changes, right? The sheer number of codes that are removed from the model certainly has an impact in the kind of output of the model, and the fact that CMS notes that the payment reduction will be a little bit north of 3%, 3.1% payment reduction. As I recall in the notice, I think they translated that to maybe $11 billion in less spending as a result of that change. So clearly from a mechanics of how the model works, it's a significant change, but also kind of financially from a government spending perspective, that is a significant change as well. So certainly would put that number 1. The GME, IME change in the rates is certainly significant, but I would also not overlook the fact that nothing was done on the Part D risk model as not a significant change, but maybe a significant thing that did not happen given the big changes that IRA made to the Part D benefit for 2024.
Thanks, Matt. Yeah, thinking about things, you've been obviously reviewing and assessing these annual advance notices and final rate announcements for many years. Are there anything payment or policy related, in this advance notice that surprised you that wasn't on kind of your radar? Whether, it's a policy change or a payment change, any wild cards in here?
Well, I was surprised that we did not see a change to coding intensity, right? There's been don't need to tell you, a lot of chatter, a lot of discussion around coding intensity. And so I think a lot of the folks kind of in the policy world were potentially expecting a change to that coding, the minimum coding intensity adjustment. We did not see that. CMS proposed to continue to do the minimum amount of coding intensity, and instead did this, as I noted, kind of much more technical change around the risk model itself. So that was certainly surprising when we got the notice earlier this month.
Thanks for that. I know there's been, like, when this the advance notice was initially released, there was sort of different analysis about the impact of all the various changes to Medicare Advantage and sort of, the net impact. So based on your review and analysis, does this represent kind of a net payment cut or reduction? And if so, by how much?
Yeah, I mean, if you look at even CMS's estimates of change in plan revenue compared to last year, they state that would be about negative 2.25% payment reduction. And that's a function of really three things. The fee-for-service rate being lower than it has been in previous years. Changes in the number or star rating changes, right? The number of plans who are in a star rating that results in a payment increase is lower for a variety of reasons. And then, as we just talked about, right, that 3% payment reduction as a result of the risk model. So taking those all together, even using CMS's revenue announcement that they put out with the fact sheet, they state that it's a negative update of a little over 2% there. I would stress, though, there will be plan-specific impacts, right? This is not kind of a universal change across the board. Enrollment characteristics matter, and that certainly is true on star ratings. For the fee-for-service growth rate, that's going to matter based on geography and the risk model, right? Who you have in your plan, the conditions of those enrollees, that's going to have a differential impact. You will see a differential impact because of those factors on the risk model change. So it's always important to talk about averages and national changes, but like anything with the MA program, it often is plan specific and geographic specific as well.
That's great. Yeah, let's dive into the risk adjustment model changes a little bit more. We're getting some questions here. Obviously, you went through in a lot of detail, kind of stepwise fashion of all the changes to the risk adjustment model, but I think there's been a lot of focus on kind of the removal of these 2,000 plus codes and its potential impact on MA and beneficiaries. Why don't you maybe expand upon that a little bit, and then I'll get into some specific questions we're getting from the audience. Obviously, a lot of focus and attention on this, and not only the impact on Medicare Advantage, but really from a beneficiary perspective at a high level.
Yeah, absolutely. And I'll start by saying that at Avalere, we have some of the, I will call kind of best minds in terms of risk adjustment. We have folks that have worked at CMS for years on this particular issue, have built some of the CMS risk models. So I will certainly not do it justice compared to those folks in terms of their expertise. So we certainly, for folks who want to, can go deeper on that front. I think it's important to kind of distinguish the two changes that they're making, right? There is a technical change around, right? The healthcare system moved from ICD-9 to ICD-10. So there's a bit of kind of just remapping kind of those codes to conditions. And that's certainly a process that CMS probably would inevitably have to do at some point, given where the healthcare system and coding had gone. There's a second piece of that, which is really a policy choice that CMS has made, and they kind of go back to this document from several years ago around their kind of overarching principles of how risk adjustment should work. And for the real risk adjustment wonks in the room, they reference Principle 10, which talks about kind of where maybe there shouldn't be big differences in coding or between fee-for-service and Medicare Advantage. And so what CMS proposed to do was, take a look at the codes where we do see more coding in Medicare Advantage than fee-for-service and remove those codes as part of the risk model. A little unclear, at least to me. I think, we'd have to dive in a little deeper, of the, just short of 2,300 codes that were removed, how many were removed because of that ICD-10 transition, and how many were removed because of this kind of Principle 10 policy decision. And I think that's an important distinction for folks to really suss out.
Yeah, and as you mentioned, these dropping of the codes almost operates as like a coding intensity adjustment. Wonder if you could talk a little bit about kind of the precedent. Is this something, that CMS has made changes to the risk adjustment model before, and kind of what are the implications here?
Yeah, CMS has made a lot of changes to the risk adjustment model over time, right? I think this is, I don't think they go one for one, but right, this is version, I think, well, I won't say what number version is because I'll get it wrong inevitably, but it's certainly up there. So CMS has made changes in the past around risk adjustment. Congress has required changes to risk adjustment in previous years. Most recently, when they enacted the 21st Century Cures Act several years ago. In that law, Congress did require CMS to provide a bit longer of a comment period than what CMS is doing here. CMS is under no obligation to do that here, and they put it out with the advance notice. So that is a little bit of a different kind of process that CMS has used in the past, but CMS has a tremendous amount of flexibility to create and update a risk adjustment model based on the statute that they live by in the Medicare Advantage program.
Some questions, Matt, coming in from the audience on the risk adjustment model changes and the elimination or removal of these codes. Wanted to get your thoughts on if this have a disparate impact on certain like subpopulations in MA, thinking here about dual eligibles, medically complex patients, low income, underserved communities. And maybe talk through maybe the potential implications there.
Yeah, it will undoubtedly have different impacts on different patient subpopulations because it's kind of a condition by condition, type model, right? So the first thing to look at is which codes were removed and which conditions are those codes related to. And so we put out not a comprehensive list, but I think top 10, maybe top 15 conditions where we see the biggest percent or most codes removed from those conditions. And I referenced a couple of those: major depression, diabetes, vascular. So there's a couple of ones where that impact is certainly going to be bigger than maybe some of the other conditions where you didn't see different codes change. In terms of kind of characteristics of enrollees that are not condition focused, right? Dual status, LIS, for instance, you'd really need to look at, what are the conditions that people who are dually eligible tend to have, and are those ones, are those on the kind of list of changed codes, so to speak. We'll get the coefficients. You can take a look at that. That will also give you a little bit of insight into how this will impact different populations. But undoubtedly, this will not be a uniform change for all enrollees. It will be very much different depending on those circumstances.
Thanks for that. And after this webinar, we'll definitely send that Avalere analysis. I think it was really helpful on the changes to risk adjustment model and the codes there. And just for our participants too, we'll be sending the slides out to participants after the webinar as well. Question here on the risk adjustment model changes. And really this gets into, Matt, kind of the rationale CMS has used for some of these changes, particularly getting in the weeds here a little bit. Your thoughts on the use of Principle 10. So there's sort of these guiding principles that CMS uses in kind of updating risk adjustment models. Principle 10 was sort of the the rationale for why they focused on these codes. Wondering your thoughts on using Principle 10, and the question here is like, should these principles really be all thought comprehensively and used together as opposed to kind of singling one out to make this change? And just your thoughts there.
Yeah,
a lot to unpack in that question, but
yeah, absolutely. I mean, it's a good question. It's a good question. I mean, obviously, I can't speak for CMS and kind of their motives and their rationale. I think it is very apparent in the kind of recent time, the amount of scrutiny that there's been around coding generally and the difference in coding between MA and fee-for-service. So I think a lot of folks are expecting something in this document related to coding and CMS's response to that. As I said, right, I was anticipating maybe more of a change around the coding intensity adjustment, but CMS obviously went a different route. This, use of Principle 10 sounds very similar to maybe some of the kind of criticism and chatter around coding. So it's in hindsight not surprising that they're leaning on that particular principle if their kind of policy goal was to try to get at some of the differences between fee-for-service and MA. I'll leave it up to our, the real pure risk adjustment experts, but to a layman like me, it does make sense to think about all principles in totality when you're putting together something. But I think certainly there is a potential there in terms of a counter argument to CMS.
And a lot of these codes that were kind of, proposed to be removed from the risk adjustment model, are really for chronic conditions, particularly diabetes. Is there anything kind of in the advance notice that spells out the rationale beyond sort of this coding differential? Like, why would you choose diabetes HCC codes for removal versus, other conditions?
Yeah, I mean, some of it's going to be technical in terms of like ICD-9 and ICD-10 by definition don't overlap perfectly. And so you have to figure out what tracks to what and what does not track. So there's a bit of, it'll drop for technical reasons. But again, there's also the rationale around differences in those codes in fee-for-service and MA. I don't think we have great information from CMS on at the code level why they removed this one compared to why they removed that one, and that maybe is a bit frustrating, but I think we don't have that level of rationale. I think it's at the model level kind of rationale for why CMS moved the way that they did.
A lot of questions here on the risk adjustment model, but here's one that's a little bigger picture to kind of zoom out. So obviously a lot of complicated changes being proposed here to the risk adjustment model. There's the impact of stars, that's included in the advance notice that were already finalized, but are impacted here. And then there's new changes. There's new changes in the proposed rule. Kind of bigger picture zooming out, Matt, what are the kind of the top three implications, in this advance notice for Medicare beneficiaries going forward?
Well, I would say, not in any particular order, right? The beginning of the implementation of the IRA is going to have a big impact on beneficiaries, right? Beneficiaries that reach catastrophic will not face cost sharing. That's a significant change. Beneficiaries that take insulin, right, their cost sharing will be capped. Vaccine cost sharing will be lower. So certainly the implementation of those provisions has a significant impact on Medicare Advantage enrollees. The other impact that enrollees will see is really a function of kind of how CMS finalizes some of these provisions, if they choose to do so, and plan response, right? And how plans will bid against that. And the output of that really is plan premiums and supplemental benefits available to beneficiaries. And so that's a extremely complicated math problem that's going to be geographic specific and plan specific, but that's how MA enrollees will kind of we'll see a tangible impact from this rate notice, is not in kind of the dollars and cents of what plans will get paid, but the plan response and the ultimate, premiums and benefit consequence. And that's a little bit TBD depending on, again, as I said, will CMS finalize this stuff in April, and what do plans bids look like in June?
That's really helpful. I think from the beneficiary perspective, what these are complicated changes, but really, what does it mean to them for their premiums, for the availability of $0 premium plans, potential loss of benefits, that are covered under Medicare Advantage currently, but not available in fee-for-service. Those are some of the things I think people need to keep front in mind when you're thinking about analyzing this and developing, thoughtful comments. I wonder if we could just touch on potential implications on the provider side too, Matt, particularly those providers that are, leaned into participating in value-based payment arrangements and Medicare Advantage. Do you see any implications there on kind of the provider side of these various, payment changes?
Well, yeah, I would say two, right? So certainly plan payment has the potential to impact provider payment underneath those, MA networks. Plans will have to adapt to differences in payment, and they have several levers that they can use. We talked about a couple already, right? Premiums and benefits, but certainly payments to providers is another lever that plans can use to adapt to kind of CMS policy change. So that's maybe writ large. Specifically for those provider groups that are maybe taking risk for MA enrollees within those MA networks, they often, their payment is, linked to what the plans are getting paid for those enrollees that they're taking risk on. So again, going back to that kind of notion that the MA risk model changes, for example, are very condition specific. If I'm a provider who's taking risk on a certain subset of enrollees, I'd want to know what the MA risk model changes are for those subset of enrollees, because that probably affects my payment amount that I'm, taking risk on. So whether it's for, patients with CKD or, other types of patients that we see providers taking risk on, that kind of condition specific impact, I think will be really important.
Yeah, and sort of the interplay between that and, the policy goal really is, further accelerating, value-based payment and Medicare overall, and, encouraging providers to take on more risk, responsibility for, managing their patient population. This is something I think that, warrants closer scrutiny and looking for unintended consequences here as we think through all the changes. I think that concludes the audience Q&A. I'm going to double check real quickly, but I think we got to about a dozen questions, which is great, and really appreciate everyone's participation here today and all the thoughtful questions. Obviously, if there are additional questions that come through, I'll be sure to pass them along to Matt as we kind of continue through the process. But I don't know, Mary Beth, do you have any closing remarks you'd like to end with here?
How could I never have any closing remarks? Matt, thanks so much. This is really helpful. And Greg, thanks for pulling this together in such a timely way. BMA is here as a resource to our allies, and know that you all are continuing to do your own analyses. So please let us know where we can be helpful in any way. And we'll tap into Matt as well on that front. And also where you all are completing your reviews, we welcome feedback on what you're seeing. Obviously, hopefully people will be participating in the comment period process, which is so great that we have that opportunity. But as I started at the top in our initial review, we were seeing some dramatic cuts that we were quite concerned about that would impact beneficiaries. So we want to be able to get your feedback on what you're seeing in your analysis, and also if you're issuing any press statements, please share them with us if where you want to. We have everything on our website. And also we've set up an additional website, don'tcutmedicareadvantage.com. And the reason we did that microsite is that we know we have a plethora of information on our BMA website that obviously relates to Medicare Advantage, but a lot of additional research and press releases that are in other years that continue to be helpful. But we wanted to create a site that was sort of just in this moment of the advance notice. So please stay in touch with us, and we'll be engaging with all of you. And obviously let us know if those allies who have membership organizations, if you're at a point where you are doing advocacy at the national, state, or local level, please let us know where we can be a resource and to engage with you. So that's it for me in my closing. Any remaining questions before we sign off? All right, thanks again.